Hey guys, so today we'll be going over tuberculosis. More specifically, we'll be covering some background in which we'll go through a description, just what it is, some risk factors. We'll also be covering some precautions that we take for tuberculosis, clinical manifestations, diagnostic testing, and the treatment of tuberculosis, namely like the drugs, first line, second line drugs. And that's it. All right, so background on tuberculosis. So it's an infection by a bacteria. The bacteria is called tubercle bacillus. It's gram-positive. It's an acid-fast organism. There's certain risk factors for tuberculosis. So for people who are more susceptible to TB, those include medically underserved populations such as ethnic minorities or homeless, immigrants from Asia, Africa, Latin America, folks who are immunosuppressed or who have HIV disorders, folks that have who are basically IV drug addicts or IV drug users. Also, there's institutional residents and workers. So there's people who are patients in hospitals who don't have TB yet, or just people who work in the hospital, such as nurses and doctors. So these populations are more susceptible to tuberculosis. Tuberculosis also has precautions. So by now we're very familiar with airborne precautions. So what are they in relation to tuberculosis? So these airborne precautions aren't instituted until the induration reveals a PPD of being positive. So it can also be instituted prophylactically. So what that means is prophylactic tuberculosis precautions can be instituted until final diagnosis is made. So these airborne precautions are consisted of what? So one, private negative pressure room. The door is shut. The second is an N95 respirator mask. So can you guys name some other diseases that need airborne precautions? So those are your MTVs, right? So in addition to tuberculosis, there's measles, varicella, and SARS. These airborne precautions for tuberculosis can only be lifted when the patient is considered free of tuberculosis. So that means that they have 3 consecutive negative sputum cultures. So once they have these 3 negative results, they can also return back to work. Clinical manifestations of tuberculosis. So there's 2 phases, right? There's an early stage and there's a late stage. So in the early stage of tuberculosis, a patient will have low-grade fevers. They're gonna be really tired, right? So fatigue and lethargy. They're gonna be coughing, right? So this is gonna be prolonged and a persistent cough. It could be non-productive or productive with mucus sputum, and this cough will last typically longer than 3 weeks. The patients can also experience chills and night sweats, weight loss, and anorexia and pallor. So if you take a look at this picture here, those are all manifestations. Late stage, they're going to have hemoptysis and shortness of breath or dyspnea, and they're going to have chest discomfort or pain. All right, folks, so on to diagnostic testing for TB. Just let me zoom in here for a second. All right, cool. So diagnostic testing for TB includes screening, right? So if a patient exhibits signs and symptoms, like we discussed before, of TB, for instance, low-grade fever, fatigue, night sweats, we're going to test them for TB. So the first step is having a PPD skin test or a MOD2 skin test. So this test is unique because it involves an interpretation. So this is really important, right? So it's first of all, it's a shot that is so it's an intradermal injection in which it'll create an induration. So basically, the results first after the shot or after the injection we're going to have to wait 48 to 72 hours in order to assess or to check for induration. So the induration is not erythema or redness, right? So that's very important. We're not measuring the redness. We're actually going to measure the induration. So if the induration meets the criteria, we're going to have a second step. So if the PPD is positive, we're going to confirm the diagnosis of tuberculosis with a chest X-ray and a sputum culture. One unique detail about the PPD test is for people who have received the BCG vaccine. They're going to test positive for TB. So in these patients, they're going to need a chest X-ray to confirm diagnosis, or actually take a quantiferin TB test, a blood test. So what the quantiferin is, the alternative to TB skin test, and it's unaffected by previous BCG vaccination. So we talked about the measurement of the induration. So essentially, if the measurement of the induration meets these following criteria, then the test will be considered positive. So what I mean by that is, so if the induration is 5 or more millimeters for populations that are infected with HIV, then that's considered positive, right? The reason why HIV patients have a small threshold for the induration and the test being positive is because they have an anergic response. So HIV patients' immune systems have a dysfunction, right? So that results in an anergic response to the PPD, and the test may reveal a negative result. So when a person is infected with TB, they do not react to the PPD. They are said to be anergic. So this population, in addition to HIV patients, this test is positive for a measurement of 5 or more. Also includes organ transplant recipients and immunosuppressed patients. So the next is, so the induration of 10 millimeters or more is positive for populations such as recent immigrants from high prevalence countries, IV drug users, and residents and employees of high-risk congregate settings. So for instance, a nurse. So if a nurse is suspected to have tuberculosis, then they would just need an induration of 10 millimeters or more to be considered positive for TB. Other types of people in this category also include people in homeless shelters or nursing homes, or basically anybody who is in the environment who is susceptible to TB. And for those people, for those other people who are not around TB, which is actually pretty rare, because we all go out in the malls, and we go shopping, we go to restaurants, we go to bars. So it's going to be rare for you to be in this category, in my opinion. But so for people who have no known risk factors for tuberculosis, they need an induration measurement of 15 millimeters or more. All right, so on to treatment of TB with drugs. So with drugs, we have first-line drugs and second-line drugs. So for these drugs, we'll be going over side effects and also nursing implications. So for first-line drugs, we have isoniazid, or INH. The side effects here are we have neurotoxicity and hepatotoxicity, optic neuritis, and peripheral neuritis. It also can cause nausea, vomiting, and abdominal pain. So the most important aspects of the side effects are, we should remember, is neurotoxicity and hepatotoxicity. So in hepatotoxicity, we have to make sure that we monitor our liver function test, right? Just to assess the level of toxicity. So nursing implications for INH, we also give vitamin B6 or pyridoxine, and this prevents neurotoxicity. This prevents neurotoxicity. We also have to make sure that we remember to take it on an empty stomach. Since it causes hepatotoxicity, we really have to monitor our Tylenol intake and avoid alcohol. And we have to monitor jaundice. So rifampin is a second drug of the first-line drugs. So the side effects here are hepatotoxicity and red-orange body secretions. So the red-orange body secretions can show up in our urine, our feces, our sweat, and our tears. This is also cause peripheral neuropathy, GI disturbances. So nursing implications. So we have to teach the patient to avoid alcohol. We want to give rifampin on an empty stomach with plenty of water. So about 8 ounces of water, 1 or 2 hours post meals, pre and post meals, sorry. Actually, I'm sorry. So 1 hour before a meal or 2 hours after a meal. For rifampin, we also have to remember for the patient to avoid taking antacids with the medication. And since it's hepatotoxic, we also have to monitor jaundice. So for our third drug in our first-line drugs, ethambutol, so some side effects are that it allows for optic neuritis, peripheral neuritis, skin rashes, and GI disturbances. So along with these side effects for nursing implications, we really have to our priority is to contact the provider immediately if visual problems occur. So that kind of addresses the optic neuritis side effect of ethambutol. So ethambutol is actually the most common substitute drug when there is toxicity in INH or rifampin. So just keep that in mind. So the fourth drug is pyrazinamide. With this, I think the most important part is just for the side effects, and so this drug increases the serum uric acid, and there's photosensitivity. Second-line drugs. So second-line drugs is mainly the antibiotic of streptomycin. So what do we know about streptomycin? It's an aminoglycoside, right? So the side effects for streptomycin is ototoxicity and nephrotoxicity and hypersensitivity. So ototoxicity, so that's going to affect our 8th cranial nerve, right? So CN8. So nursing implications that relate to these side effects, specifically for ototoxicity. So as nurses, we should obtain a baseline or remember to obtain a baseline audiometric test and repeat every 1 or 2 months. Just assess for ototoxicity. And since it's nephrotoxic, we also want to measure or monitor serum creatinine levels, just to assess like how the kidneys are functioning. So that's it for this concept map on tuberculosis. I hope you enjoyed it, and good luck in your studies.